Hola,
Hola,
students,
students,
professionals,
professionals,
and
and
teachers.
teachers. Thank you very much for listening to a presentation about home care in the Netherlands.
Hello, my name is Jonty Schoonhagen, and I've been invited by Meerte Joosten to help her with a presentation about home care. Myself, I've worked for about 6 to 7 years as a district nurse in a city called Almere, which has about 200,000 people living in it. And after the 6 or 7 years, I've worked for 3 years as a manager, coordinating 4 or 5 teams of district nurses and registered nurses. Now, as of today, I'm in my second year as a lecturer in nursing, so it's all yours.
Thank you. My name is Meerte Joosten, and I also worked as a nurse in home care, but I worked in a small village with little people. But I also worked as a nurse in a hospital on different wards. And now I focus more on research, and my aim is mostly on lifestyle in people with prostate cancer, and we aim to improve exercising in people with prostate cancer. And I'm working for almost 3 years as a lecturer in nursing now.
So before we take a look at how a day of us would look like, we would like to take you on a little trip about how district nursing or healthcare in general is organized in the Netherlands. So first of all, there are quite a lot of different organizations. I think in the city where I worked alone, there were about 40. And typically they are semi-privately funded. So the healthcare for the client is typically funded through insurance policies, through which a client can just select one and they'll fund the healthcare. And another option would be that the healthcare is funded by the government. That sort of depends on what kind of situation and what kind of healthcare situation the client is in. So it could be really different for clients. Usually long-term would be government, and short-term would be like insurance companies. That's mainly the shift of it. Well, healthcare in the home situation would be provided by small teams, around 12 to 15 individuals who are all schooled, either nurses or nurse ADs. Later on, we'll talk a little bit further about the roles about district nurses and registered nurses, and maybe Meerte, you can tell us a little bit about what care ADs would do.
Yes, because I worked as a registered nurse, but before I did that, I also worked as a nurse aide, because then I did not finish my education yet, and then my tasks were mainly focused on the daily care tasks. So I helped them with a lot with washing and very much of the daily care task. But then when I was a registered nurse, then I did more of the nursing procedures. So you can also think of them catheterization or stoma care and stuff like that.
Yeah. So as you can see, we work with different levels, and that's also necessary because not every client needs every level of care. So we make adjustments to that. And while the work area usually depends on the amount of clients you have. Typically, if you have more clients, your work area decreases, so it's getting smaller. And usually the teams work from around 7 o'clock in the morning till 11 o'clock in the evening, and there tends to be a night shift as well. And can you tell us a little bit about the different shifts in the working area?
In the team where I worked, there was a shift in the morning, a shift in the afternoon, but also a shift in the evening. And sometimes I worked a morning and afternoon shift, or sometimes I did the afternoon and evening shift, or sometimes the morning and evening shift. So that was fluctuating. And in the morning, I helped the clients with to start their day, to help them with their clothes or washing. And in the afternoon, it was very different because some people I help them to go to the toilet, but also sometimes you have the wound care, and in the night you help them to get ready for bed.
Yes. So the teams would like provide care for a client around combined with the night team for about 24 hours a day, and depends how heavily it's organized. But usually the teams under guidance of a district nurse would be responsible for the healthcare for patients, while the doctors, medical specialists, or specialist nurses are responsible for the medical policy. So you would work together to provide healthcare for a patient or client living at home. Okay, so typically in the Netherlands, you would work with quite a lot of different healthcare specialists because usually you'd talk and work together with a doctor, a medical specialist, specialist nurses like wound care, diabetes, lung problems like COPD. And you would also work together with mental health care companies, physiotherapists, but also social workers to like organize together the healthcare situation to make sure people are able to live as long as possible in the home situation. So first of all, after you've had a sort of an image of how healthcare is organized in the home situation, we would like to take you on a little journey of our experience, how we've worked in the past couple of years. So first of all, imagine me working as a district nurse. I'd get an email or a cell phone call to check whether we would have time for a new client. In this case, Mr. Janssen. If I'd accept it, we would get information through a secure transit or email, or I would just ask the doctor of course, with permission of the client, if I could do a background check whether there are some diseases or other available information about the client. Then afterwards, I would call the client and organize a house visit. So I usually take my bike because I worked in the city and my working area was pretty small. So I take my bike to a client, but for you it was different, right?
Yes, because I worked in a smaller village and sometimes it was very far. So mostly I took a car. Sometimes in the summer when the weather was nice, I could also take my bike.
Yeah. Depending on the working area, you'd either take a car or by bike, but we never walked or took a public transport. After a house visit, I would check what the original problem was, and I'd usually go do an anamnesis with the client to check what care was needed. I'd take a look at the wound and do the first healthcare, so I treat it. And to treat it, I just look at the treatment plan we received from the hospital, because their specialist nurses or just the doctors would prescribe a treatment plan. After that, I'd look further, so I'd check the client in total, and I'd also look at the living arrangements. And in this case, Mr. Janssen, I'd see that there's a neglected household, which would raise some questions, because why is it neglected? Is there some problem? And in this case, I'd also noticed that there might be some memory loss. So in the healthcare plan, I'd state that we need to treat the wounds, that we want to cure them. We'd describe how often we would do it. In this case, probably 2 times a day. And also I would note the neglected household and the risk of memory loss. So I could ask my colleagues to check it, whether there's any progress or any worsening. And I could ask the municipality to arrange for someone to help with the household. After this, I'd give the healthcare plan to my colleague of Meerte, and she takes it over.
Yes, and then when I start my shift in the morning, I will go to Mr. Janssen and then I will first read the healthcare plan which Jonty wrote, and then I will see, oh, the wound needs to be treated like this, so I will do that, and I will also check how it's looking, and I will report something about it, because maybe I think, oh, this wound is getting worse, so we need to do something different, or maybe it's getting better, and then we can do some less. But I also check on how Mr. Janssen is doing, if he has if his clothes are dirty or not, and if I think he's showering well because of the neglected household, because maybe he has memory loss and maybe he can't do it himself. So maybe we need to arrange some extra care tasks. And when I see that, then I will talk to Jonty again to say, hey, I see this. Can you maybe arrange something else?
Yeah. So if I edit from it, there's more suggestions of more problems around the memory. Then I could talk to a case manager dementia, and she would run a MMSA, which is called a mini mental state exam, to check whether there's a problem, and if there is, they'll contact a specialist to look for a diagnosis.
So hopefully this example will give you a view about how we have different roles of nurse in home care. So as I told, I worked as a registered nurse, but Jonty worked as a district nurse, and he will tell you some more about the things he did.
Yeah. So typically my day would look like the following. I'd usually start with a small meeting with the rest of the team to just take care of some minor things or some changes. Then afterwards I would do about 2 or 3 hours of direct patient care. And after that, I would just be busy with either healthcare plans, the financial side of the healthcare system, improving that. So registration of errors, improving errors, finding ways how to improve the healthcare within the team, but also communication with different healthcare providers and or other teams to organize healthcare and improve it mainly. Usually it also involves some coaching of other nurses, but mainly on the side of like attitude or communication within the team to make sure everything glides along smoothly, as we do not have a manager directly in the team, but only a manager on the side who is always working on the headquarters, something like that. So my focus would be on the coordination of the district care, whilst the focus of Meerte would be providing care for the clients. Maybe you can take us along with
In
that
my
one.
day, yes.
Yeah.
So I mostly focus on providing care for the clients. So I start my shift, and it depends if I have the shift in the morning, in the afternoon, or maybe in the evening. But in the morning, then I start, and then I will visit the patients and help them with their daily care. And also I observe the patients on how they're doing. Maybe they are feeling a bit lonely, or they have also a neglected household, and I will take some actions. But I also do lots of nursing procedures, and I help them with things like the daily care tasks, like washing, but I also help them with their medication, or maybe give them some injections, or help them with their diabetes regulation. Sometimes we have more complex procedures like the catheterization or maybe stoma care. But also we have the terminal care. So sometimes when people they are dying and then they are at home, so then we visit them and we give them medication so they don't have any pain. And we also support a family who is with them.
Mm-hmm. And what might be good to know, actually, I just reminded myself. What's also good to know is that usually you have a registered nurse who's like responsible for a patient, who's sort of like the first contact, and usually they are responsible for coordinating the care and how do you call it? Talking or having contact with the doctors or the apothecary around medication, etc. So that's sort of like how it's organized around the daily care.
Yes,
Yeah.
sometimes when I give the medication, then I notice, oh, why is someone getting this? Maybe it's not necessary anymore, and then I will call the doctor and I will, yes, I will talk to them about it and maybe make adjustments.
So what you see right now is the nursing indication process, which is one of the main things in healthcare in the home situation, and sort of like a process which you do in a loop, which you continually redo until the healthcare either stops or isn't necessary anymore. So you'd start with an intake, like that's your first meeting with the client or their partners. And you usually use not a checklist, but just a conversation with the client to check whether there are health problems or different kind of information. Alongside with the conversation, you'd use a list of diagnoses, which you usually get from the hospital or from the doctor to check whether there's an underlying problem. And you'd use that to determine, together with the patient or the client, what the goal would be of the nursing care. So that goal sort of determines what my colleague Meerte would do in the daily care, like taking care of a wound or checking whether the a home situation changes or whether there's problems with the memory. After that, the goals will be translated to a nursing plan, which can be checked before providing healthcare. And before that plan is made definitive, we do allocate time, and the time allocated would be the time Meerte could use for the client as well. But the allocation of the time differs quite a bit because you have to take into account the problems and the complications of the client. So, For example, if you have compression stockings, which you use to prevent water in the legs, for example, you could get about 10 minutes for that. But if you have a client who has got memory problems or maybe some other problems, you could get up to 20 minutes. So it really differs per situation. So after you've allocated your time, as a district nurse, you would check whether which disciplines you need. Like for this instance, I could communicate with the mental health company, or sorry, I have to correct myself, with case manager dementia, but it could also be necessary for different healthcare situation that I need a mental health care company or a social worker, depending on the situation. After that, I'd have to coordinate with the team to arrange daily care, to make sure the healthcare plan is integrated with our planning system, to make sure all the clients are generated on the list, to show where they live, how late the healthcare is needed, and so everyone would know what to do. After that, I'd assign a responsible or registered nurse or nursing AD who's responsible for the client, who's going to coordinate the daily care for that client as well. And my last action would be a planning of the re-evaluation of a needed nursing care, which would usually be around maybe 4 weeks after the initial intake, and then you'd create a loop. So after the re-evaluation, we would take another look at the goals set. Are the goals completed, or do we need to make new goals depending on different circumstances? So that's sort of an overview of how the nursing indication process works in the Netherlands, and you'll just continue this loop until the patient has no longer need of healthcare.
So we also have some challenges in the Netherlands when it comes to care in general, but also when it comes to home care. For example, elderly people live longer at home. This is mostly because we have a shortage on nursing homes. So people who normally should go to a nursing home, they can't go because there's a long waiting list, and so they have to wait and they have to stay at home much longer. Moreover, the people who are at a hospital will be discharged sooner. So normally you would recover in a hospital, and then when you are better, you will get home. But now they will be discharged early, and then they will be home sooner, and then they get the care at home. So that is also why the complexity of care is increasing, because people are more sick when they are at home and they need a different treatment. Also, in the Netherlands, we have a very aging population. So we have lots of older people, and this will increase in the future a lot. Also, because of the shortage of nursing homes, this is a really big problem. And in combination with the growing cost of healthcare, it's even a more bigger problem. Then we also have a shortage of nurses. So we have not enough nurses to take care for all the people. So it's very difficult how to arrange it. And last, in the Netherlands, we have little involvement of family in daily care. In the Netherlands, it's not normal when your parents will get older or will be sick that your parents come and live with you. So then you don't look after your parents, and that's a bit difficult. We also have some solutions we are working on to help to improve this. And the first solution is with technology, and I will show you some options of that later. Moreover, we try to involve the family in the healthcare much more than we do now. Also, we try to enlarge the social network of the patient, because sometimes when people are getting older and they're getting a bit lonely and they're living alone, so we try to improve the social network so people will watch them. And last, we try to do very much home adjustments, so people can stay at home much longer. And I will also have some examples for that. So I want to show you a few examples of some possible solutions we use in the Netherlands. First of all, we do a lot of home adjustments, so it's easy for people to live at home longer. One example of this is the stair lift. Sometimes when people are physically not able to walk the stairs anymore, we build a stair lift. And that is because in the Netherlands, the houses have lots of stairs. So when people, most of the time people, when they go to sleep, their bedroom is upstairs. So they need to walk the stairs. Therefore, we built a stair lift for them. But also when people are physically not able to shower while standing, we put a chair in the shower or maybe something they can hold on to. So it's more easy for them and they can still do it by themselves and they don't need help for that. But also lots of people who live at home longer, they get memory loss. And one example to help with that is the Medido for medication. So normally when they can do it themselves, a nurse needs to go there to give them the medication, but with the Medido, the box will do it. So at certain times when people need to get their medication, the box will give it and they will know, okay, now it's time for my medication and take it. So they don't need a nurse for it. Also, sometimes when people have a risk for falling or other risks, they can get a sensor for an alarm. So they have a necklace with a sensor, and then when something's happened, they can push the button, and then someone from the home care team will come and see what's the problem. Also, sometimes when people have more severe memory loss, but they still live at home, they sometimes leave the house and they go wandering around and then they forgot where they are. So then we can use a GPS tracker to locate them. So these are just a few examples. We also have sometimes then we use like a calendar for people who forget the days. So there are lots of adjustments we do there and also in technology.
So we would like to thank you for listening to our presentation, and we hope we have enriched you a little bit about how healthcare or home care is organized in the Netherlands. And yeah, thank you very much.
Yes, thank you as well. And we also would like to invite you to ask some questions about our presentations through the live connection we will go to right now. So thank you very much. Bye bye.